Hi, so as a bit of an introduction, so I'm Lindsay Thomas, some of you might know me, so I've been a GP in Sheffield for 18 years, but I largely work as a menopause specialist now in the Leeds NHS Menopause Service, and still do some general practice. Unfortunately, the way the meeting's been set up isn't allowing me to share my screen, so I'm going to have to be a little bit Chris Whitty with asking Claudia to move my slides along for me. So I've been asked to do an overview of the menopause. There were going to be two sessions on the menopause, one an overview, a more basic overview, and one more of a masterclass. So I've tried to, but there's now only one session. So I'm trying to combine those together. And I'm hoping that there'll be something for everyone to take away, because I know that obviously there's going to be a broad range of experience and confidence with the menopause. So if we can just move on to my first slide, please. So I'm hoping to look at why menopause is an issue, what are the symptoms, how do we recognise it, how do we make a diagnosis, and then looking at what are the actual risks and benefits of HRT, trying to dispel some of those myths that are out there, and then moving on to a bit of practical prescribing, vaginal estrogens and some non-hormonal options. Next slide, please. So looking at why is this important? So it's important because 51% of the population are female, and up to 75% of women do have symptoms, with 25% of women finding these really debilitating. And with life expectancy having been increasing all the time, an average woman will spend a third of her life postmenopausally. So it's important that we recognise it and help women find ways of managing this transition and symptoms that they might experience. 1 in 10 women will think about leaving work during this time. And sadly, 45% of women, when they've been surveyed, haven't consulted a healthcare professional. I think probably we're all aware that that is changing, although not in all practices around the city, depending on what demographic you work with. But there is, since there's been a lot more media exposure and awareness, we are seeing a lot more women coming forward. So it's important that we know ways of helping women manage this. So can I have my next slide? So it's not just, we're not just talking about patients, and I thought it might be helpful to put this slide in, because when
you're mute.
You've been muted.
I'm really sorry, I don't know why I've been muted. So just going back to that slide, I think it's important that not looking just at patients, but having a look at how that's impacting on doctors, but it will also be all clinicians, obviously. And when a large number of female doctors were surveyed of menopausal age, you can see that nearly 100% of those were affected by symptoms of the menopause, with 90% of them saying it had impacted their working lives and needing to make changes because of that. Next slide, please. So, there should be a little bit more on this slide as well. So if we look, well, just looking at, if you click on, is there another slide?
There's slide 6, is there?
Thank you. So looking at this slide, you can see why there are issues at the moment in how we're managing the menopause, because there were some big studies which came out in the early 2000s, which looked as though really overestimated the risks of breast cancer and heart disease related to HRT. And you can see from these graphs that prescribing was quite high in the early 2000s and then pretty much overnight stopped. And for those of us who were working at that time, when I first started work, we were still prescribing quite a lot of HRT, and it did pretty much stop. So as clinicians, we've not had an awful lot to offer women, and women have also been reluctant to come forward because there were a lot of myths and fears surrounding HRT for them as well. So how we've been managing this until the last few years hasn't been really helpful and effective for women, and we can see that from the surveys that have been impacted. Sorry, I keep being muted.
Sorry, Lindsay, I'm not sure why, because it's not me muting you.
That's all right. Next slide, please. So if we look at a couple of definitions, so the menopause is only a diagnosis that can be made retrospectively. So it's essentially the last period, but women don't know that they've had their last period until 12 months. So essentially the menopause refers to one day in time when we know that it's been 12 months since the last period. Anything before that is when women are starting to experience symptoms but still having periods is the perimenopause, and that can happen for anything but any time between 5 to 10 years before periods stop. And it's really important that we recognise this time frame. And don't miss it, because women are still having periods, and if we're only looking at that as a guide, then we can miss the fact that women can be experiencing significant symptoms during this time as well. The postmenopause is anything after the menopause. So we often talk about going through the menopause. And whilst it's true for lots of women that their symptoms will settle anywhere between 4 to 8 years from their last period, some women can have symptoms much longer than that. And the long-term health implications of lower estrogen levels continue lifelong because those hormones are never coming back. So postmenopause is where women will sit for the rest of their lives. So in the UK, the average age of the menopause is 51 years, with anything between 45 to 55 for periods to stop being seen as completely normal. Anything under 40, anything between 40 and 45 is seen as an early menopause, and anything under the age of 40 is a different condition called primary ovarian insufficiency, which needs to be managed in a specialist setting. And that group of women, it might not be that their periods have stopped entirely for 12 months, but over a 4-month period, we should be considering this in women who are having irregular or absent periods over a 4-month time frame, and then doing necessary blood tests to try and make that diagnosis. And it's not as rare as you might think, with 1 in 100 women under 40 and 1 in 1,000 under 30. And then there are other reasons, obviously, why women can become menopausal due to surgical or medical treatments for things like endometriosis, or as a result of cancer treatments as well. Oh, if you can just go on to my next slide, that's great. So the perimenopause is something that we do really need to focus on for the reasons that I was saying earlier, in that it's easy to miss, but this can be a significant, can you see that slide? That it can be a significant part of women's lives. So if we look at an average age of the menopause of being 51, if this can start anywhere between 5 to 10 years before, we are looking at symptoms starting in their early 40s and even late 30s for some women. So there's a diminishing pool of follicles in the ovary. So there's less, but there's also a decreased quality of those follicles. The body copes quite well in the beginning and can compensate quite well. So rather than periods stopping, what you can actually see is that cycles become closer together. So rather than being a 28 or a 30-day cycle, which might have been expected for that woman, that you can often get women saying that their cycles will have shortened sort of 23, 24 days, and the heaviness of the flow can change as well. As the number of follicles reduces, then those cycles obviously become more drawn out, periods start to be missed, and then finally stop. In the perimenopause, the hormone levels are also very erratic. In the postmenopause, women have got low, stable levels of estrogen, but in the perimenopause, the levels are really fluctuating, and sometimes levels can be really high of estrogen, sometimes they can be really low. It does tend to be the low levels that women experience their symptoms from, but because of that fluctuation, women can also notice that their symptoms are really variable, so they can go for weeks at a time without any, and then have a period of time where things are worse. And sometimes that can coincide with their cycle as well. So in times in the cycle when estrogen is at its lowest, so just before a period or the start of a period, women can find that their symptoms are worse, or that they start to get new onset PMS, or their pre-existing PMS worsens. Next slide, please. So looking at symptoms, and it's estimated that there's around 35 to 40 symptoms which can be associated with the menopause transition, but obviously a lot of those could be attributed to other symptoms as well. So the trick in sort of recognizing that this is menopause is talking to women about what's happening with their cycles, not just about missed periods, but have there been any changes, and also looking at asking about other symptoms. If women are coming perhaps with palpitations or something like that, asking in this age group of women, have they noticed any other changes as well? So if you just move on to my next slide. So it's not all about hot flushes, which are obviously those symptoms that we commonly associate with the menopause transition. And I'm sure what you're seeing in your surgeries, and I see as often the most significant issue for women, are psychological and cognitive symptoms. So 69% of women report mood symptoms, and that can be anything from anxiety, low mood, irritability is a really common symptom, and also tearfulness, often for no reason. And then cognitively, women noticing that their concentration and focus aren't as good. They can have some word finding difficulties and what can be described as brain fog, just that they don't seem to be able to focus in the same way. And obviously that can be really tricky, particularly for women in work. Sleep is often disturbed at this time, and it's well recognised that hormones not only stop women from being able to get to sleep, but it also causes lots of night wakening and generally less restorative sleep. Often what women will report is that they get off to sleep okay, but they wake in the early hours of the morning and are unable to get back to sleep again. And obviously that has a knock-on impact on how people feel mood-wise as well. And it's important to note that the age group of 45 to 55 has the highest suicide rate amongst women. Obviously, there's lots of other life factors going on at that stage of life, but it is important that we bear the menopause transition in mind with women who are experiencing mood difficulties, and nice supports that we should be thinking about HRT to alleviate low mood that is happening alongside the menopause transition. And we will all have seen women who have seen other specialists or been started inappropriately on antidepressants at this stage of life. And I think that's probably the most common medication that's given out during the menopause transition, perhaps because people feel more comfortable with the side effects and risk benefit profile of that than they do HRT. But HRT, for the vast majority of women, it has far more benefits than it has risks and is suitable for most. Next slide. And then if we think about physical symptoms, so as I said, we're all very familiar with hot flushes and night sweats, palpitations, increase in prevalence in the perimenopause transition, often when those hormone levels are fluctuating. Women can experience a change to their body shape with a central tendency to central weight deposition, which hasn't been there before. Headaches are often troublesome, and that can be generalized sort of tension headaches, or it can be that migraine disorder starts for the first time or worsens. So as we know, women who suffer with migraine often do better when things are as stable as they can possibly be. So we'll know that changes in sort of diet, changes in sleep can impact on migraine, and the hormone fluctuations of the menopause can do that as well. Joint and muscle pains, and we'll often see women who've been diagnosed with fibromyalgia or referred to rheumatology, whose symptoms improve really well once they're started on HRT. And obviously the cycle changes that we've talked about as well. Next slide. So, and it's really important that we don't forget what used to be known as vulvovaginal atrophy, but has now been retermed genitourinary syndrome of the menopause, because we know that the bladder is significantly impacted as well. And unlike the other symptoms, it's estimated that 70% of women over their lifetime will struggle with some genitourinary symptoms due to the menopause. And rather than, although these can start in the perimenopause and menopause, they can come on much later in life, and it is a chronic, they are chronic symptoms and won't get better without treatment. And because vaginal estrogens are so risk-free, it's really important that we do recognise, treat this and ask women about it. So some women will present with recurrent UTIs, or we've all seen those women who come with recurrent thrush and issues like that, and they can be treated for that over and over again, and we never really get to the root cause. So symptoms that women can experience are, as I've said, dysuria, urine infections, vaginal dryness, soreness, burning, discomfort. Some women can experience a change in discharge rather than just dryness. And for some women, this can be discomfort just during sex. For other women, it can be that they find it difficult even to sit down. So really important because it's so easily treated. Next slide, please. And it's important to think about the impact that estrogen has on women's bodies. So estrogen is really protective for bone health and heart health. And as women go through the menopause transition, they become more at risk of both. So 1 in 2 women over the age of 50 will have osteoporosis, and a 50-year-old woman has a nearly 3% risk of death related to a hip fracture in her lifetime. There's an increased risk of metabolic syndrome with insulin resistance and an atherogenic lipid profile, and cardiovascular a risk of any cardiovascular event is increased because of the way that the vascular endothelium function is affected directly. Next slide. So making a diagnosis very much is on bleeding patterns and symptoms, and in women over the age of 45, NICE guidance is very clear that we don't need blood tests to diagnose either the perimenopause or the menopause, and this extends to women who are amenorrheic either because of progestogen contraception, ablation or hysterectomy where they've had their ovaries preserved. And they can actually really muddy the water, because if we do blood tests on women who are perimenopausal, depending on where their hormones are at that time, we can often get normal blood tests, but that doesn't mean that they're not perimenopausal. And in women who are menopausal, we've already got the diagnosis from the fact that their periods have stopped, they've got symptoms, so we don't need a blood test to confirm that. Between 40 and 45, it's reasonable to consider an FSH and other investigations if you think they're needed, because we don't want to miss things like thyroid problems, etc. And under 40, there are extensive investigations needed to investigate women who may have POI. Next slide. So moving on to, and next slide again, please, moving on to risks and benefits of HRT. So often there's lots of myths and concerns surrounding the actual risks and benefits of HRT, largely relating to cardiovascular disease, venothromboembolic risk, and also breast cancer. So if we look at, when we go on 2 slides, we've gone back a bit. And the next one, please. So if we look at cardiovascular disease, so far more women, and just back again, please, far more women die of cardiovascular disease than do as a result of breast cancer, but that tends to be women's main concern at this time, and clinicians. So estrogen replacement in HRT is actually associated with a significant reduction of cardiovascular disease. And there's something which exists called the window of opportunity hypothesis, and that's come out of studies which have shown that if HRT is started before the age of 60 or within 10 years of their last period, that women actually have a significantly reduced risk of cardiovascular disease. So rather than us being concerned that if we start women on HRT, we're going to increase their risk of heart disease, actually we're going to do the opposite. Over the age of 60, it's slightly more complicated, but on looking at it on the whole, the risk even in this age group appears to be neutral, but they don't get that protective effect because their body has already had chance to experience changes due to low estrogen. Tablet HRT does slightly increase the risk of stroke, but not if we use it through the skin. Next slide, please. We've already talked a little bit about osteoporosis, so we know that there's that increased risk, and HRT is incredibly protective in maintaining bone health, but bone density, but also treating osteoporosis, and it can be used as a first-line treatment in primary ovarian insufficiency, but also in menopausal women under the age of 60. There's been quite a lot in the media about dementia risk in HRT, and it swings between there being an increased risk of dementia with HRT to it being, it's going to stop everyone from getting dementia. And at the moment, the evidence that we have suggests that the risk is neutral. Next slide, please. And in terms of VTE, so it's often thought that all types of HRT increase the risk of VTE, and that's often extrapolated across from the combined pill. But actually, it's only increased by oral estradiol because of the way that it's metabolized and the fact that it goes through first pass metabolism in the liver. The risk associated with estrogen through the skin is no greater than someone's baseline risk. Alongside estrogens, progestogens do have a little bit of an impact on VTE, and micronized progesterone is the progestogen of choice if there is any increased risk of VTE, alongside with a Mirena coil or using a combination transdermal patch. But I would suggest avoiding things like oral Provera or norethisterone if you've got someone that's at risk. For women that are at higher risk, so women who've got a strong family history of VTE or someone who's got known to have a hereditary thrombophilia, it is recommended that those women should be referred to haematology for assessment before considering HRT. It's likely that those women will be able to have transdermal estrogen, but it's about identifying those who perhaps should be anticoagulated and haven't been, but also in the rarer thrombophilias, they haven't been included in a lot of the studies that have been done looking at clot risk. So it's good to just get, just some advice and guidance from haematology about whether they feel happy with that situation, which on the whole with transdermal they do. Next paragraph. So breast cancer is what everybody worries about the most, and the risk of breast cancer diagnosis associated with HRT is often overestimated both by healthcare professionals and the public, which often limits access to HRT. But it's important to note that most women won't be diagnosed with breast cancer in their lifetime, and the risks of HRT are comparable or often less than that of lifestyle factors, things like obesity, alcohol intake and exercise. And in women with a low underlying risk of breast cancer, which is most women in the population, the benefits of HRT use for up to 5 years will exceed potential harm. And that doesn't mean that women can only use HRT for 5 years, but it does mean that those risks start to change with the duration of use, although it still remains very, very minimal, the risk that is conferred by HRT. In women who have got primary ovarian insufficiency, the years of HRT exposure should only be counted from the age of 50. So we wouldn't say that they have any increased risk of breast cancer up to the age of 50. And that can be extrapolated across to women who are perimenopausal. So we don't think that the risk of breast cancer increases up to the age of 50 because they could be having normally circulating levels of those hormones up to that point. And interestingly, the risk that's been shown with HRT has only ever been shown in slim women. It's not been shown in women who are overweight or obese, so the risks are slightly different there. Next slide, please. So in terms of HRT, the risks are not all the same as well. So estrogen only HRT is associated with little or no change in the risk of breast cancer. Combined HRT, so where you've got estrogen and a progestogen, can be associated with an increased risk, and that appears to be duration dependent and also varies with the type of progestogen used. So the risk from HRT doesn't come from the estrogen on its own. It is to do with the combination with progestogen, and then there are progestogens which are more breast friendly. So micronized progesterone, utrogestan, and dydrogesterone, which is found in the UK and Femiston, are associated with a lower risk of invasive breast cancer comparatively to other progestogens. Mirena probably sits somewhere in the middle. So the more old-fashioned types like northisterone and Provera are slightly less breast friendly. They're still not breast unfriendly. They're not carrying huge risks, but the other ones are more breast friendly, and Mirena probably sits in the middle. And vaginal estrogen isn't associated with any increased risk in breast cancer. Next slide, please. So you're probably all familiar with this infographic, but if you're not, it's on the Women's Health Concern website, and it's quite useful in explaining risk to patients. So if you've got 1,000 women between the ages of 50 and 60, 23 women will be diagnosed with breast cancer over that 5-year period, whatever. And then if you look at the second column up from the bottom, if you made everybody overweight or obese, that would double the risk of breast cancer. And on the second column down, second row down, if you gave everybody combined HRT, only an extra 4 cases of breast cancer would be diagnosed. And this infographic can help women to look at what their own background risk is. So if you look at the bottom row, that looks at exercise and the risk reduction that confers, and also looks at things like alcohol, smoking. So you can help someone to understand what their own background risk is and also the impact that HRT is going to have. So if you had someone who has got a healthy weight, they drink within the recommended limits of alcohol and they exercise regularly, but take HRT, they're likely to be at a lower risk than someone whose weight falls into the obese category and drinks outside the recommended limits. So it's good to look at it that way. I'm just going to speed on. I've only got 5 minutes left in the meeting. Sorry, I've tried to cover as much as I can. If we just move on to the next slide. And the next slide, please. So the next slide, please, otherwise we won't have time to go through. And next slide, please. So there are some contraindications and cautions that we need to think about, and NICE guidance has a really good summary of those. But the problem with them is that they don't distinguish between oral HRT and transdermal HRT, which carry different risks. So on that list, there's all of the things that you would think about. So breast cancer, estrogen-dependent cancers, undiagnosed vaginal bleeding, but there's a good list to refer back to there. Next slide, please. So nearly everyone can have transdermal HRT. So often it's thought that people with who have a high BMI, migraine with aura, any risk factors for VTE, hypertension, diabetes, or any of the cardiovascular risk factors wouldn't be able to have HRT, but transdermal is perfectly safe in this situation. But obviously those things need treating as well. Next slide, please. And something which often causes confusion and often means that women are advised not to have HRT is a family history of breast cancer. And most women with a family history of breast cancer won't have an elevated risk themselves. So there's a really good, nice guidance on familial breast cancer. Again, that takes you through exactly who is at higher risk or not. But as a rule of thumb, if they've got only one first or second degree relative over 40, they would be classified as low population risk. So I see lots of women referred into secondary care clinic in Leeds who have been told that they can't have HRT because they've got a relative with breast cancer, but actually they are low population risk. And obviously that creates anxieties for them, but also means that they've been denied HRT. Next slide, please. So in a menopause consultation, things that you want to know, symptoms and periods, their past medical history, any of those things which might impact on prescribing. And sorry, I've not got more time to go into each of those individually. Family history, particularly breast cancer, VTE, osteoporosis, how they've got on with hormones previously, because that helps to guide prescribing. Any medications that they're using which might impact on HRT, so enzyme inducers, which would speed up the metabolism of progestogens used orally. Lifestyle factors impacting on breast cancer, cardiovascular and VTE risk, BP and BMI, and also do they need contraception? Next slide, please. And then it's worth thinking about what is HRT. So they want estrogen for their symptoms and progestogen to protect against endometrial hyperplasia and carcinoma, which is why most women who've had a hysterectomy only need estrogen. Next slide. So your first decision to make is, do they need estrogen only or do they need combined HRT? So estrogen only, estrogen and progestogen are needed for anyone who has still got a uterus, but we need to think about it in certain situations as well. So in women who've had a hysterectomy, we want to know what type of hysterectomy is it. If it's subtotal, they may still have some endometrial tissue in the cervical stump that's been left, so they need to have a 3-month trial of combined sequential HRT to see if they bleed. If they do bleed, they need to have continuous combined going forward. If they don't bleed, if they do bleed, they need to have continuous combined. If they don't, they can have estrogen only, but they do need that trial. You also want to know what the reason for the hysterectomy was. Was it for endometriosis? Was it for endometrial cancer? If it was for endometriosis, it's recommended that they do have a progestogen alongside the estrogen to prevent activation of any endometriosis in the pelvis and the potential for malignant change if those deposits are having unopposed estrogen. And we need to remember anyone post-ablation still needs combined HRT, and anyone on any progestogen contraceptives other than Mirena does need a progestogen. Next slide, please. And then how to decide who needs sequential and who needs continuous combined. So the way to make that decision is not based on age, it's based on bleeding. So a sequential preparation is used in women who have still had a period within the last 12 months, because if you went to continuous, they would be likely to get irregular bleeding and you wouldn't know when to investigate. So these are monthly regimes which have a progestogen element in them for a minimum of 12 to 14 days to allow those women to have a withdrawal bleed. Next slide, please. And continuous combined is used in anyone who is postmenopausal, so hasn't had a period for a year, and anyone who is amenorrheic for any other reason, so either due to ablation or contraception, because we want that thin endometrium to be maintained. They don't need to have a bleed. And continuous combined is a daily dose of estrogen and progestogen. We need to remember to swap over from sequential HRT to continuous at some point. So trials have shown that between 1 to 5 years of sequential HRT, there won't be any increased risk of endometrial cancer, but at 5 years, it looks as though there might be. So looking to swap women over anywhere between 1 to 5 years, depending on what their pattern of bleeding was before. If you've got someone who was bleeding really regularly, you're probably going to want to leave it a few more years. If you've got someone who had only had 2 periods within the last year before they've started on sequential, you're probably going to be able to swap over a little bit sooner. Next slide, please. So should we always use transdermal estrogen? And the answer really is no. So the older fashioned types of HRT are often, just as effective and often more convenient. But there has been a real, particularly since the Davina documentary, there's been a real push to what's termed body identical HRT, which mostly looks at estrogen through the skin and micronized progesterone as a capsule. But it's important to note that all estrogen in HRT is estradiol, so it's all body identical, and not all progestogens are bad. And some of them are actually better for bleeding control. Some of them are just better tolerated for whatever reason than the more natural types. So it is worth remembering that we've got all of those options. Transdermal does have no increased risk of VTE, as I've said. Women tend to get more physiological serum levels because it doesn't have to be metabolized. It has a better impact on lipid profiles, and there's lots of women who it would be better for VTE risk, those sorts of things. But it doesn't mean that we shouldn't consider tablet HRT, because for some women it's much more convenient, it's easier to remember. And often with transdermal options, apart from the combined patches, women are needing to remember 2 things. And we often see that women forget to take the progestogen, or they don't like that part of it, so then they can be using unopposed estrogen. So it's important discussing with the patient in front of you what their risk factors are and what's going to work best for them. Next slide, please. So I'm running out of time. So Claudia, do I need to stop or can I carry on?
Yes, please, just because we've got another session coming up. So what we're going to do is we're going to share the recording and the slides with everybody. So whatever we have missed, hopefully will be covered there. If you do have any questions, you're more than welcome to put them in the chat and we'll try our best to respond to them as well.
So I'm really, really sorry. It was really hard to do an overview in half an hour. So I hope that I've covered, I think the risks and benefits are really important to look at. So hopefully I've covered that there. I don't know if anybody's got any really burning questions that they wanted to quickly ask me that I've not covered, but otherwise, hopefully that will be in the slides that you'll get. Okay, so if anyone has any questions, if you pop them in the chat, I'll try and answer them there. But otherwise, you're welcome to, obviously you'll have the slides to have a look through as well.
I think we have a question from Leanne. If you have a few minutes, Lindsay.
Yeah, absolutely.
I was just wondering about the risks of VTE when you've got people on progesterone who then start accumulating other risk factors for it. And do you have to switch what you're doing for them?
In terms of one of the sort of
gains a lot of weight or takes up smoking, or there's some other risk factor comes into play for their VTE risk, does that, I mean, is there any, do you have to do that when you see them every year?
In terms of swapping between, yes, so that's why an annual review is really important, because at each review you're going to be looking at, does the risk benefit profile still look the same for them as it did when you first started prescribing? So if you'd got someone who, for example, their BMI had gone above 30 and they were on tablet HRT, then you'd want to look at swapping them to transdermal. Yeah, does that answer that?
Yeah, thanks. Yeah, thank you.
Are there any other questions, Claudia?
Could I ask, please, is there any evidence at 10 years, any data for 10 years?
For using it in terms of risks?
Yeah.
So we know, so there is data which extends beyond that 5 years, and we know that, do you mean in terms of breast cancer?
Mainly, yes, please.
So if someone had been started on HRT within that 10-year window and they continued to use it, they would still get the cardiovascular disease protection, they'd still get the bone protection. It's not that that risk changes. With breast cancer, we know that the risks do increase with the duration of use. and obviously the background risk of breast cancer is increasing with age also, but those risks still remain very minimal in comparison to lifestyle factors. But it is a discussion to have at that annual review about, you know, and women being aware that that risk is increasing with time. And that's why it's a different situation when we're prescribing HRT in women outside of that 10-year window, because they're not getting the cardiovascular disease protection. So then the benefit risk profile becomes different.
Thank you.
Is that no problem? Any other questions, Claudia?
Can I ask a quick question?
Yeah.
So I remember ages ago, this is about 25 years ago, learning in medical school that it was the fluctuation in hormones that caused the symptoms. But it seems to be, I see a lot of women now who, you know, 10 years past that, and they're still getting symptoms. So have we changed our understanding of what it is that's causing the symptoms?
I've been in here since
No, I think it is that it's not just the fluctuation. The fluctuation plays a part, but it's the low estrogen levels. So that's why women experience symptoms both in the perimenopause as they've got those dipping hormones, but also in the menopause when they've got low consistent levels going forward. So that's why we can see women who started with symptoms perhaps in their late 40s have now come to see you in their late 50s, and they've had symptoms all that time which aren't improving. And it's just due to the body, the way that the body responds to those low estrogen levels. So the fluctuation can be difficult during the perimenopause because it can be difficult to predict what those symptoms are going to feel like, but it is the low estrogen that women where the symptoms come from. And I think you've probably all got other sessions to go to now, haven't you? So if there's any other questions, just shout out now, but otherwise I will leave you to your afternoon. Thank you.